So we haven't. I just want to say welcome to everybody. We're going to prepare for our first live case for today. I want to thank the team here from Media Ventures, from our AV team, to help us get this case off to show you guys live. Our nurses, our techs, and our anesthesiologists. Obviously, we can't do any of these cases without them. So I'm going to introduce Dr. Pasham, who's going to sort of tell you about the case we have today. Ram?
Thank you, Dr. Patel. Next slide, please. But today we'll be presenting, as Dr. Patel said, a complex IVC filter retrieval case. It's truly an honor to kick off our first live venous case. In brief, this is a 46-year-old male, history of remote PE 15 years ago, for which a IVC filter was placed in the setting of cessation of anticoagulation for cholecystectomy. Due to an episode of mild COVID, he ended up developing symptoms consistent with Lurie's syndrome, was found to have aortic and iliac artery occlusion, for which an aorta bifem bypass was placed. He started developing abdominal pain and lower back pain and pressure, which was exacerbated by movement. And I'll go into the imaging later. The pertinent history is otherwise listed on the slide. Next slide. On presentation, he was known for having a little bit of hypertension, but otherwise labs are normal. Physical exam is otherwise unremarkable. Labs are normal. Workup for musculoskeletal causes of pain was also unremarkable. Next slide. So this is a cross-sectional axial CT. All right. Well, we'll show you the images live. Go ahead. Next slide. So the filter is extremely tilted, as you see in the fluoroscopic images. We've already obtained right IJ and left common femoral vein access, particularly because the filter is tilted towards the lateral aspect, directly facing the left common femoral vein in parallel. So we already have two 18 French sheets ready to go, and we have forceps available, and we're going to retrieve this filter using forceps.
Thanks, Ram. So I'm just going to show you the photo file image here. So this is the filter. It's an old barred filter placed about 15 years ago. You can see it's severely tilted. On the images on the CT scan, it looked like the cone was at least touching the wall, possibly penetrating the IVC wall, and a lot of these legs are out. One of them was actually, I think, touching the vertebral body in the back. So basically, we got access. We did a venogram, which was normal. Everything was open. And so our plan is to use Lymol forceps. So here I'm going to show this. If you guys could zoom in on the forceps here. If you guys have seen this before, it's over here where my hand is. So it's a metal forceps for removing. It's a endobronchial forceps. Let's see. You can see it there. Yeah, there you go. So it comes designed straight. We just manually put a bend on it. These things are reusable, so we will autoclave it and use it again for other patients. And so that's sort of what we're going to use here. So we're going to try from above first to see if we can just grip it and pull it out, grab the cone. If we can't, the idea is to come from the left groin. As you can see, the angle of the IVC filter sort of pointed towards the left common iliac vein. So hence coming in from the left groin and seeing if we can grab the neck of the filter and sort of twist it off and then grab it from the top and remove it from above. Are there any questions, I guess, from the panel or anything?
Mm-hmm. I can't hear anything. So,
any questions?
I'll ask you a question, Rahul. So how frequently are you going straight to forceps before you attempt any of the other complex retrieval techniques like, hangman or, basically multiple?
So yeah, usually, no, you can't grab it there. If it's not so tilted, we'll try, obviously we try our snare and usual catheter system first, but if it doesn't work, then we'll move to this. For this patient, just given how severely tilted it was, we knew there you go. Sometimes twist it off. We knew it wasn't, not so much. Okay. And then we knew it wasn't going to work. So hangman, I've had like mixed results with it, so I tend not to do hangman.
And what are you doing with the anticoagulation for this patient at this time? Does the patient come in fully anticoagulated? Are you giving heparin?
No, he's off anticoagulation. So again, it was sort of a weak indication to begin with. So we did give him a little bit of heparin to start the case. You're not in. You're not in. It's at the edge, right?
Yeah.
So here. Yeah. So that's what we'll do. We gave him a little bit of heparin just to prevent clot as we do this.
Hey, Rahul, it's Kush Desai. Question I have, did you do multiplanar cavography before, just to kind of lay out where that tip is?
Yes, exactly. Yeah, we did a couple of runs with the And we're still off the side. Yeah. Sorry. Yeah, so we did a couple of runs just to see exactly where the hook is. The CAT scan shows it pretty well. And what I'm trying to do is I'm trying to grab just the cone. And right now we're kind of stuck. Oop. So it looks like we're able to get it off the wall. It's just sort of tilted. Luckily, it's fairly low, so I'm not going to fall into the renal veins. Still two. Oh, I could have got in there.
Oh, you're close.
Almost.
I know. Oh. I think I got it now. Nope.
Are you using laser sheets for any of these?
So we typically do not. Sort of have it now.
Looks like you're in the sheath or war. Yep.
Yeah.
So while he's working, Kush, I'll ask you a question. So sometimes you can fold these at the neck, and he's kind of trying to grab it and sheath down over it. And sometimes you can kind of get a fold in it and just take the whole thing out and get that upper part out. What do you think about that with the G2?
Yeah. So I think with nitinol and single piece laser cut nitinol, and looks like he's going to have success right there. Very
Nicely
nice.
done.
Nicely done.
Yeah.
You can fold it for sure. I'm with single piece laser cut nitinol. You can't fold it from the neck. You can invert it from the groin. And then with anything that has weld points that's not nitinol, so the Conochrome filters, which are Cook filters, I would not. You can fold the hook. You can't. You shouldn't really fold below that bushing.
Yeah. So the other thing we did, and more so for the trainees, I think, is we did a bunch of single shots before we did this procedure. Before we started, we took a single shot of the filter, counted the legs. We also took a single shot of the lungs to make sure there's no pieces in there before we do it. And so here you can see we got the whole thing out. Sort of, it looks like all the legs are. All the legs are there. And it looks like it came out in completion. So we'll do another set of single shots, and we'll do a venogram. We had actually had the access from below just in case. Normally we would leave a safety wire from above if we didn't have the groin sheath, just in case if we did end up with a tear or a rent that we could get across, so we don't end up with a big problem.
And actually, with the safety wire, I have a question. If you let's say this was one of those closed cell filters, like an option or a tulip. Have you ever had an issue with the wire literally going through one of those loops, and then you've got the filter, but then the wire now becomes a part of the complex with the filter when you're trying to collapse it?
Yeah. So in those ones, I'll tend to actually just leave like a micropuncture in the groin and then leave a safety wire up. But for like these ones, it usually a safety wire down, not an issue. Right? But like a trapeze or something like that, it can be a big pain in the butt. So we're going to do a venogram here. We're going to aspirate the sheath. Yeah, and we did this with general anesthesia. For these complex ones, you never really know what you're going to get yourself into.
It's contrast.
Yeah, go ahead. You can do your run.
Yep. Ready?
Yep. Do you have enough? You don't have enough.
Let's get another.
You never really know what you're going to get yourself into, so we tend to move to do these with general anesthesia, or at least with anesthesia. I don't know, Kush and you guys, if you guys are doing the same thing.
Yeah, it really depends on how the imaging looks beforehand. Like with this, if it's a significant amount of forceps work, I agree. At least MAC anesthesia, and then depending upon patient factors, general anesthesia. If I'm going to invert something, then general anesthesia for sure.
Yeah, I agree.
Yeah, for sure.
These can be, the Limal forceps can be painful for these patients when you're torquing it in the back. And so it's helpful to not have them awake for that.
So the cavogram looks great here. If you did have, and you fortunately don't, but if you had a contained extrav or rupture, what would be your go-to tools to sort of have on board?
So we actually have the Reliant balloon here somewhere. So we would put a Reliant balloon up just to temporarily occlude, or at least sort of tamponade. And then if we have to, I honestly, I can't remember the last time we had to put a covered stent in the IVC. Some people have gotten away with just a big wall stent in the IVC because of the closed cell nature of it. But I don't know. What are you guys doing?
I've used aortic occlusion balloon. I've never placed a stent graft. I don't know if any of you guys have.
We've done it a couple times, but usually place a wall stent, if anything at all.
Yeah, usually can get it to stabilize with balloon and prolonged. Maybe wait like 5 minutes, leave the balloon up, and usually it seals off.
Right.
If you have used
Yeah,
a balloon,
I think
what size balloon do you use for this? I mean,
Yeah, that's a good question. What size balloon would you use for a cava this size, Rahul?
So we're using the Reliant balloon, which is the aortic occlusion balloon.
So yeah,
goes
so
up to,
like a coda. You know, some of them, I think they come in 27, 29, 33 sizes. I just pick one. I usually do like a 29.
The smaller coda is what I use.
Me too. So recently at UCLA, we've had a run of complex filter retrievals that did well intra-procedure, did well on the venogram post. Perhaps there was, in one or two cases, a contained, perforation that was managed with ballooning. And the patient was in the PACU for 2 hours before suddenly dropping pressures, became hypotensive, brought back to CT, brought back to angiography, and essentially needed covered stent graft placement. And so we're discussing a protocol for these patients that we're bringing in, especially if they have permanent filters that are causing symptoms, where a filter has been in for 20 plus years, to maybe come up with some sort of protocol for a lower threshold for getting these patients imaged postoperatively, just to make sure that we don't have any more of these M&Ms. I'm just wondering if on the panel here, when you're approaching filters that may have, infrarenal or filter-related thrombosis, or filters that have been in, like a simonitinol or something that's been in Greenfield, that's been in for 20 plus years, is there any special imaging, or are they staying postoperatively longer, or are there any measures in place for monitoring these patients or for making sure that you don't have bad outcomes?
So my personal experience with filter retrieval has been that usually if there's going to be a complication, it happens on the table. It doesn't happen in a delayed manner. And if a complication seems to have occurred in a delayed manner, you might have not quite seen something. I'm not saying that that's the case. It's just been my experience. But in general, if it's not my device and it's been in over 6 months, get a CT scan, make sure you know exactly what you're dealing with, make sure you have everything on board, you've planned out how your anesthetic plan is, and that you have your bailout tools nearby, right? Because a ruptured cava needs to be dealt with, very quickly.
So in Michigan, we take out a lot of greenfield filters since they were placed, sort of created there. We take out many of them that have been in for years and years. And what we generally do is, if we're worried about something, which in general we kind of are when we're taking out a greenfield, I find IVUS actually shows you the rent in the cava much better, because you might see it might be posterior, you're not seeing it well, there's double density. And so we actually do IVUS and you can see it, and then you can sort of deal with it that way.
Yeah, the greenfields are interesting. I haven't had a problem with the stainless steel greenfields. We've seen issues with the nitinol greenfield, the one with the wavy legs. We've had issues with those. There's a lot of contact points there.
So for those, what we've been doing is, once you grab them with the forceps, you sort of push them down a little bit to disengage the legs, and then we pull them into a dry seal. It works really well to pull them into a 20 French dry seal.
Question from Brett.
Yeah. Rahul, it's Brett Wickman. You mentioned before indications for this particular removal, and several years ago when a lot of this controversy developed, we were getting a lot of those requests. Hey, I want my filter out. And there were pretty soft indications for many of those, and we kind of debated how we were going to go about handling that. It seems to be less, but can you touch on the panel or
Rahul, so we
mention when you take them out?
So he had, obviously he's younger, right? So he's only like 42, 43, somewhere around there. So he's not on anticoagulation. And he has this back pain, which, he's been worked up with an MRI, X-ray. He saw a back pain specialist, and, they can't really find a cause. These legs are penetrating and they're out. So it's sort of what we're left with to blame. And we do have this discussion with we see all these patients preoperatively and talk to them about, that we're going to take this out. It may not make your back pain better, but I can't prove that it's not causing your back pain until I take it out, right? That's kind of where we're stuck with this one. And the thing is, it's severely tilted, it's penetrated. These things will probably get worse. With this, specifically this filter, I'm a little worried about it breaking at some point as well. So it also sort of filter dependent, but we do have this sort of long discussion with them about the risks and sort of benefits of removing it.
Yeah, I mean, the other issue is that there are safety communications from the FDA. So 2010, 2014 really didn't qualify much about the patient other than that patients that are acceptable procedural candidates globally, if a filter is in place and it's retrievable, you should consider retrieving it. And that was in response to Nicholson and a couple of the articles from the late 2000s that showed fracture, embolization, death. So yeah, it's difficult, right? And it's individualized. You don't want to apply a blanket policy, but in general, if a patient's as an appropriate procedural candidate and the filter is no longer indicated, then we usually go forward with it. But I have turned down some where it's like, I have one patient that I'm following now for 4 years. Her filter is completely transverse in the vena cava and half of it's in the caudate lobe of the liver. And she's asymptomatic. So no data applies to her. I'm just following her.
Right.
I mean, I think some of the hardest part is when do you bring these patients for removal? And if somebody's like this, they have a chronic filter, you know it might be challenging to remove, but they're not on anticoagulation. I think probably, like you're saying, we should be kind of trying to be more aggressive and at least evaluate those people and discuss with them possibility for filter retrieval.
Right.
I think it's also
I mean,
important.
we also talked to him too about. Sorry.
Go ahead.
Sorry. Yeah, we also talked to him just about if we go in and it just doesn't want to come, if it's totally stuck or if the superior aspect is totally penetrated through the IVC wall and we can't get it out, that we would just leave it. That was sort of also in the discussion, right?
I was just going to add that there are some filters that have reported data about higher embolization and fracture, and this is one of them. So it would be useful to get this one out.
Yeah, just as a side, I already got an email from his lawyer. So,
just have a question for the panelists and also for Rahul. This particular case didn't require quite a lot of manipulation, but let's say it did with the forceps, and then the post retrieval cavogram was fine. Are you or any other panelists putting these patients on anticoagulation for a short period of time to prevent any thrombus on the extraction site?
Yeah. So personally, I do intraprocedural anticoagulation based on how long of a cable collapse time I have. And that's primarily, honestly, with biconical filters, the Optes trapeze, where there's such a broad zone of attachment and it's a tug of war that you're trying to get out. And if you think about it, I actually, in one of my talks, I have a great picture that was taken by Bob Ryu when I was a trainee, where they did a run, and this is before the laser was widely available, and you can see the whole cava is puckered closed. And so that patient we anticoagulate. But otherwise, in general, I don't, at least.
But I mean afterwards, after they go home. I mean, you anticoagulate them during the procedure, of course, but let's say you had to do a lot of manipulation. Are you going to anticoagulate them to prevent thrombus on the basically the freshly extracted site?
I personally think only in the event of a really ragged looking IVC afterwards would I do that. That's a great point, though.
Yeah, I think you have to see some evidence of thrombosis happening or early thrombus on the wall that's going to make you worried that it's going to extend and occlude that IVC. I think more worried about, a small tear and causing bleeding with that anticoagulation than I am about the thrombus forming in that large vessel.
I think we need to wrap it up with Rahul so they can move on to the next case. Thanks, Rahul.
All right. Thanks, guys.
Thank you.